Hello. Thanks for joining us, Vicky. How are you?
Hello. Very well, thank you. Very well.
Awesome. So we're here to talk about your SCA.
Yes. So it's an exam that I was really not looking forward to. Had built it up in my mind that it was going to be a torture, and I was pretty scared of it, to be honest.
Fair enough. So why don't you tell us a little bit about yourself, where you're at in your training, where you're training?
So I'm actually a quite late graduate to medicine and introduction to medicine, so I had a career beforehand, and I'm now in the very final months of my ST3 year. I work down in the southwest. I work in Devon, and that's where I went to medical school and I did my training. And I'm working for a rural practice, so my practice is largely villages and sort of farmland up to sort of the edge of border of Devon, sorry, of Dartmoor. And I'm now finally finished all my exams. I'm now at the point where I'm compiling the last of my portfolio, and I've got my final ARCP in about 6 weeks' time.
Awesome, awesome. So it's all very rapid after passing, isn't it, in terms
It
of trying to
is.
get ready for your CCT. So you said you were apprehensive. So talk me through a little bit about what apprehensions you had, leading up to the exam.
So I've actually had quite a few problems through my training. I'm actually dyslexic, and I've known that since I was 7. So um, coming to medical school was late was probably not a surprise, and I've struggled with certain aspects of training throughout my training, and I ended up in this GP practice because I actually had to take a couple of months out of training because of stress. So I was struggling with timing. I was struggling with a memory deficit,
Hmm.
and also struggling with the practicalities of trying to juggle dyslexia alongside training and actually becoming a good GP, becoming a GP that is able to take a comprehensive history and absorb what's the patient said to them, and there's so many different strands which you have to think about in that really precious time that you're given,
Hmm.
and it is complicated, and it's so easy to miss something. And so when I, faced with the exam, I got through the AKT with well medic support, and that was really helpful. So when I got to the point where I needed, I was just sort of very apprehensive about the exam, and felt I was struggling really to get the information, the history taking, and get to a point where I was really comfortable to move on in the consultation.
Yeah, no, that makes sense. And if you now think about having taken the exam, and if you compare the apprehensions that you had leading up to the exam, how would you say your experience compared to the exam itself?
So the exam itself actually went really well for me, and I know a lot of trainees have had real difficulties with the system, with the um, with the recording. I was very lucky; I didn't have any problems, and uh, it went smoothly. Um, the actors were actually really pretty good at giving me the cues necessary to pick up. Wasn't 100%, so there was
Hmm.
occasional situations where we're getting to the management plan, and they slipped in a bit of a bomb. I'm pretty certain I had asked you some of these questions, but actually, altogether, I think what the important thing was is I'd had plenty of practice beforehand, and I'd built a confidence level that I could go through the system. I could go through the consultation and be safe and get all the information, get especially the psychosocial information early, get all of the playing cards out on the table, and then reassure myself, do my little reassurance that I'd get all the red flags, that I'd got all the safety netting. And it just gave me a real security going into the exam that I knew what I was going to see. And that actually really felt like it felt like I was well prepared going in. And
Excellent.
when I came out, it felt it had gone well.
Awesome, awesome. So I think if I think back to the first time we worked together, so the first case that we did together, if if I remember correctly, it was one on opiate overuse.
Yes, yes,
And then we did a case on prostate afterwards. And
yes.
if I remember back to that, when we did the case on the opiate overuse, you did an excellent history and there was an excellent management plan in place. But I remember you managed to do the consultation in about 9 minutes 30, and the same one, the prostate one as well. And one of the things that I felt was missing was that kind of getting the psychosocial information
Mm,
there. So yeah, and I guess one of the things that we worked on was just taking a breath and just letting
mm,
things naturally fall and just giving the patient that encouragement to share their story and things like that. So it was really nice to see that progression from where you were probably one of the only trainees that was doing it within 12 minutes. But actually, by the end, I felt that you were taking the whole 12 minutes, and
mm.
there was this really good balance between you speaking, the patient speaking, and then coming to this kind of joint management plan. So that was really good. So do you feel that your structure did get better as you kind of
Mm.
progressed through the weeks of practice?
Absolutely, and it's really helpful, the iterative process, because each week I could do the learning online, absorb some of that, um, and then during the actual training, one-to-one training, it was a very much a case of do a case, right? Where did I go wrong there? Here we go. That's that, and then I can immediately practice it, and it was really helpful because you very rarely, even in joint tutorials, get that level of care taken over exactly what you've said. How has it come across? Have you got all the information? Do we really understand where the patient's coming from? Are we, consulting with this patient with our own agenda in mind and not really seeing what's going on in the patient, and therefore opening ourselves up to missing something really important, and or not really being very medical, because we are very medical. It's understandable.
Mm-hmm.
It's what patients expect in many ways. But actually, consultations in GP are, it's a different relationship to a lot of medicine elsewhere.
Mm-hmm.
And
And
yeah, it was good.
in your in your regular practice now, do you feel that you have changed the way that you consult on a day-to-day basis? Do you find that you do get opportunities to practice some of the skills that you used during the exam?
Oh, we do. I do that all the time now. So my and it's really helpful for the really difficult days where you are. I've had a really I had a really good difficult Monday where the practice was massively overburdened with lots and lots of very sick patients, and we had to increase our capacity at quite short notice to try and cope. And actually, you going back to a structure which you've really well rehearsed and you've really honed is a safety net. And it allows you to say, well, no, I know I got this. I've done the exam. I've practiced this over, and you can just use it as a safety net and as a way of really making sure that you are, coping and safe, and actually not overwhelmed, which is, I think, really important. So
Mm-hmm.
very useful my day to day.
Mm. I guess a lot of that comes down to the uncertainty that you, I
Mm,
guess, have to experience and tackle as a general practitioner as well. And there's huge amounts of uncertainty, and there's also lots of pressures.
mm,
Where you work in Devon, it's known as one of the more difficult places to work at the moment due to the resources in that area. I guess we know that patients wait longer to
hmm
see secondary care. Do you feel those? So when I was listening back to a webinar by the RCGP when they were talking about the SCA, it's very much it's meant to reflect a modern day general practice clinic. Do you feel
mm.
that your exam did that? Did it reflect what general practice is like at the moment?
Yeah, so I think so. I think in many ways, the complexity of the cases weren't actually as complex as I see day to day, which
Hmm.
I suppose it's reassuring if you're going into the SCA at the moment. You think, well, actually, you do see a lot of complicated stuff in general practice, and at the moment, particularly, you see patients which you have this really difficult uh, medical ethical dilemma of
Hmm.
actually they need to see secondary care, and you are, and it's clearly then don't need to be immediately admitted, and you're managing patients in the community far longer than that used to
True.
be the case. So you take it, that is a lot of clinical uncertainty and concern that you take on. And I think it's really helpful to do the SCA and see where the RCGP expects us to be. And, that's really helpful in many ways.
Yeah.
It's an interesting exam from that point of view.
Mm,
It's an
mm.
interesting one.
How far into one's ST3 year do you feel that somebody should actually take the exam? Should they do it early? Should they wait till later on? I know now you have to reserve your place in advance and you
Mm.
can change it, but what advice would you give to trainees that are, thinking of doing the exam?
So I would say do it later, because when you first move into ST3, you've got to get yourself into your practice. You've got to adjust to it. There's a lot of pressure initially where you are pushing the boundaries of your time and knowledge. And I think the answer is actually you've got to give yourself time to bed in and actually do those other things in your portfolio. So the prescribing assessment and all of your assessments, get those pretty much done, because they feed into all of those things. The AKT knowledge, everything feeds into the SCA, and the SCA is sort of the final cherry on the top of the cake.
Mm-hmm.
And doing it too early, first of all, I think you can give yourself an awful lot to do in that first 6 months of your ST3,
Mm-hmm.
um, and also you don't give yourself the experience that you really need, because every single consultation you do in general practice is a practice for NSCA.
Makes sense. I'm
And you
really
can
glad you
all
said. Yeah.
Yeah, so you can always go back and reflect, well, it's like, actually, I think the patient didn't really understand what I said there, or, oh, actually, I really needed to have known that piece of information earlier in that consultation. And actually you need to have an understanding of the sorts of things the art of what is possible and what is impossible in general practice.
Absolutely, absolutely, and treat it like you would any other patient. Don't try to
Yeah.
do everything in that 12 minutes, because it's not always possible. But you should be able to signpost as to what needs to be immediately managed and what could be managed at a later point. And that feeds back to that opiate withdrawal case that we did
Mm,
together, where yes, it's about building rapport with a patient so that you can then start to think about how you're going to manage their prescribed drug addiction over time, which I
mm,
was really impressed by when we first did it together. Um, you raised some really interesting points there about just the kind of general preparation and how your day-to-day practice does feed in to actually taking and sitting the exam, and how all of the different exams and assessments do actually come together. If I think back to our third session when we switched from data gathering to clinical management and we
mm,
started to talk about management, one of the things that we talked about, and I know you did this in the last days leading up to your exam, was start to look at
mm.
management or creating lists of management options for conditions that you could expect in the exam. How important do you think it was to start thinking about management in that way, in terms of having options available that you could then feed back onto in certain cases?
Well, I think it's good practice anyway. First of all, I found I was getting right back into the guidance again, and into the BNF, into treatment summaries, and that's always worthwhile time to spend. It got me to think of options and patient preference, and actually, severity of disease. And I found that actually, sort of following the well medic lead of thinking about 5 clear management practices or ideas for common cases, was really helpful way of to just hone down exactly what you would use as a management plan in the common sort of diseases. So I don't know how many I did. I did a whole book of
I
them.
think you did. Yeah.
And I did lots of different diseases, which I would see commonly, and it was really helpful to sort of also pick out the common threads of it, and
Hmm.
the
Hmm.
importance of bringing in lifestyle advice and making sure that every interaction you have with a patient isn't just about disease, it's about promoting health in that patient, and really giving them the power and empowerment back to manage themselves if they can.
Yeah, I think it's thinking about it in is it the trimodal association of health, and looking beyond just the physical and biological
Mm,
process. So no,
mm,
that is a it's an essential skill, and I guess it goes all the way back to thinking of patients holistically. And I think it's much harder to do that in practice, because actually you're now finding that there isn't necessarily continuity. And there was a
mm,
recent article that I read about
mm,
how actually seeing the same doctor is actually much better for patient outcomes, and actually much better for doctor stress as well. So it's interesting how you know when we're in a system that is overburdened, that
mhm,
it might be difficult to do that. In terms of coming to kind of Wild Medic and how we supported you, you've mentioned about how we work together, and we use this kind of iterative approach, which is somewhat different to like mock exams, because
mhm.
we don't necessarily, in the traditional sense, do mocks. So there was never, we didn't just do like one full day of cases. We did a few cases and then we worked on them, and then you kind of implemented things for the next session. Did you feel that we challenged you enough from session to session?
Yes, so I think the benefit of the way the iterative approach is that you can hone in particularly on an area, and really you take the information that you provide, you work, and the cases were complex enough to really, you always were looking out for something. I felt they were very realistic to what I then experienced in the SCA. So each one of these cases I could have easily have seen come up, which was helpful. But I think by doing it in this sort of honing in on one area, you gave each area an opportunity to be explored thoroughly, um, and learn. So you challenge it, and then challenge it and challenge it, so that you're able to put in place immediately the feedback you're given, which is great.
Excellent. And you mentioned then there was the theory within the course that you kind of looked back on in between sessions as well, where we felt that there was something that needed to be looked at. I guess one of those areas was when we talked about results and handing
Mm.
results over to a patient, and is good news always good news for the patient, and how do you work? How do you manage your time where you've never seen a patient before? You're
Mm.
expected to give them a set of results. You've got all this information that's provided to you in the candidate notes. Do you take a history, or do you just go ahead and give the notes, and those types of dilemmas that you may face in the exam? If you were now back in, when you were first thinking about the SCA and preparing, or there's a trainee out there that's listening to this, that's thinking about the SCA, that's maybe considering our coaching program, what what should they expect, or what would you share with them in terms of what they can expect over the next 6-8 weeks or so?
So obviously, first of all, my expectation was I needed help in really understanding what the, the exam was. I'd read everything. I'd, done all the RCGP, and I still felt insecure about what to expect. And I think that was the real mine. The course gave me some real security, but it was an opportunity. You do this online learning alongside it, which showed me a really good way of thinking, and a simple way, so easily recallable way of structuring your consultation. I loved how it was divided into the patient's part and the doctor's part and the shared part, because actually that is how general practice is structured, and it was a really simple way of consulting when you're under stress in that exam. And so you get this, you do it, piece by piece. You have access to the reading materials, the video casts, and go through all that in your own time. And then you get to put that into practice, and explore areas and raise areas and say, I'm really worried about this, or actually I'm really not very good at giving results, or I don't know how I should do that. Actually, do I gather a lot of information? And so I could ask questions, and interrogate you really, and how best to approach each scenario.
Mhm.
That was really helpful, and that backwards and forwards meant that I, I was able to, when I was practicing with other trainees, which I did alongside it, I was really able to gain a lot of it. I could say, well, I want you to look at this because this is where I was weak last week. This is the area I need a bit of care and attention taken.
Yeah.
I want positive feedback. It gave me permission to ask for and listen to difficult feedback.
Yeah, yeah. No, no, it was a pleasure working with you. It really was, because you were open to constructive criticism, and I think that's a challenge. It's a
It
challenge. It's
is.
a challenge that I see with some trainees, where, especially, I think if I've had trainees that have failed an exam before, then I find that it can be a little more difficult, and you can be a bit more guarded to bringing in or being open to that feedback. But I always find that you were very, very receptive. Um, the actors that we used, how did you find your interaction with them? Because the
Yeah.
cases change from young to old, and easy to complex. So how was that interaction for yourself?
That was good. I've always managed to get myself completely absorbed, and I forget that I'm working with an actor. To the point when I was did my ALS training, I had the dummy that died, and therefore I was in tears. I was like,
Oh my,
but I did everything right. I needed a hug at the end by the
oh
course
my goodness,
instructor. So I get very quickly absorbed into the patient. And I certainly found that the actors were very good. And
yes,
yeah, they were to me patients. Unfortunately, I get
absolutely.
this.
It's the best way to do it. Best way to do it.
Yeah.
And I think that's sometimes the difficulty, because when you do work with a trainee, and I've had this feedback recently, that when you work with a colleague, sometimes your colleague's not going to challenge you in the way
Mm,
that you're going to be challenged by someone who isn't, one, your colleague, but also somebody who's not an actor. Because I think what ends up happening is you can be very receptive to your colleague naturally. So we
yes.
have
Yeah.
natural empathy. So you're probably a little bit more inclined to give information easily,
Mm,
whereas sometimes the actors are kind of coached to hold off giving information and things like that. So,
yeah.
so I think it's important.
I certainly found the actors, and in the SCA as well. Um, that's the important thing. It's really difficult to just practice between trainees, because you know what they need to know in order to get the case,
Mm,
and
mm.
and it's really difficult to hold back and not just basically go, oh, what have you, how can I help you today? And you just basically regurgitate the case to them.
Exactly, exactly that. And I guess even when ice comes into play, because we talked a lot about how not to appear
Mm,
formulaic, and listen to the ice rather than just icing patients, because I
yeah.
think it you can go that one step too far away. So what's your idea, or
Mm,
what's your expectation? How would you like to leave this consultation? Whereas often, as you picked up on lots of times, where the patient would give a cue, and actually just receipting that cue back to the patient would often be enough for them to then share the ice with them. So I think that's something that sometimes doesn't come across when you work with trainees as well.
yeah, absolutely, absolutely. And actually it's to do well, I think in the SCA, you have got to be clearly not following some sort of, format. You have got to follow a format, but you can't make it explicit.
Exactly,
That's a
exactly.
quite a
It's interesting.
skillful thing.
Absolutely. It's interesting because when we were developing this course, and I've actually never shared this with anyone before, but when we were thinking about doing the course, we did some surveys of trainees who used our AKT stuff. And we were actually probably one of the last educators to actually enter into the SCA market on purpose, because we wanted to really see what was out there already. And a lot of feedback that we received was that people wanted a set of notes of 100 cases that could appear in the AKT, and that basically questions that needed to be answered and management options that
Mm,
should be offered for that cases. And we didn't do it,
mm,
because we felt that all that we would be then encouraging is people to learn, okay, if I get a chest pain case, these are the questions that I need to ask, and these are the management options that I need to give. Whereas actually, you don't want to do that. You want to listen to that patient's perspective of that chest pain,
mm,
because that's going to massively change the way that you're then going to manage them. So no, I think that's a really interesting point as well.
mm. Yes, this is really important to. I think being trying to, there's no shortcuts, unfortunately, to passing the SCA,
Unfortunately,
because there's no shortcuts to medical education, and you've got to understand the anatomy and the physiology. You've got to understand your pharmacology, but you've also got to understand the patient,
exactly that.
and
Exactly
that's
that.
it.
It's hard. It's never easy, and it's
Yeah.
only going to get more complicated. Final question. You've been a real help, and I'm sure everyone who's listening to this is going to find it incredibly helpful, because you've given a very candid opinion on the exam and your preparation, and you've shared your intimate journey through this exam process. But if there was one piece of advice that you were to give to somebody listening to this today about the SCA, what would that piece of advice be?
So I would say start fairly early with your preparation. I probably left it too late. I got a bit panicked in the end, and that was a little bit overwhelming. So don't book yourself in for the SCA too early. This is an exam that is rigorous. It needs to be, and you need to. And and as I say, there's no shortcuts. So starting early and actually asking whoever you're training with, so that be no well medic, but with your trainer, with your supervisor, and with your colleagues, make sure that at the start of each case, work out what it is that you want to have support with. Is it the ice? Is it the management? Is it the safety netting? And have someone give you proper criticism, proper feedback, because actually it's gold. It's gold dust, and lots of people will want to skip around it and be nice to you, but the exam's not going to be nice to you. And actually, people can be, say it with kindness, and I always felt that the feedback I received was always really supportive, but you need to know where you're going wrong or what you're missing out. You need to know.
Absolutely, absolutely. No, I think that's really, really helpful. Thank you very much for your time today. It's been an absolute pleasure speaking to you about the exam, and I would like to join everyone who's listening today to wish you the very best in your career. I'm
Thank
sure
you.
you're going to make an excellent GP, and yes, I'm sure you're well prepared for anything that's going to come your way in the next 6, 12, 24 months. And yeah, and if anyone who's listening to this today is interested in signing up for Well Medic, you can head over to our website, and there's some information on both our SEA courses and coaching there. And we've also got some information on our blog as well. Thank you very much, Vicky.
Thank you.
Anything that you'd like to share before we finish?
No, it was, thank you very much.
You're very welcome.